Dear colleagues, it's a great pleasure and a great honor to welcome you here today at the session that is a session joined with the International Society of Cardiovascular Translational Research, ISCTR and ESC. And the title of this session is Cardiology at an Inflection Point, Where Will the Future Take Us? I have the great pleasure to chair this session together with Tony DeMaria, Professor Cardiology at the Judy and Jack White Chair in the Department of Cardiology, Distinguished Professor at the University of California in San Diego. My name is Jeroen Baks. I work in Leiden University Medical Center, and I would like to ask you, Tony, to start us with the first lecture.
Well, the ISCTR, the International Society of Cardiovascular Translational Research, is a society dedicated to facilitate the translation of innovation into clinical products. And the founding director is Dr. Nabil Deeb, and he will give us an introduction to this symposium, Cardiology as an Inflection Point, as we take true giants in the field to predict the future. Dr. Deeb?
I would like to thank the European Society of Cardiology Scientific Committee and Professor Bax and DeMaria for putting together such a great joint session between the European Society of Cardiology and the International Society for Cardiovascular Translational Research. Cardiology at inflection point. Where will the future take us? I think in the next decade, we should expand the cardiovascular education. Currently, we teach on the diagnosis and the treatment of diseases and how to use a product. And we have today a great session. You will hear from the world-renowned experts about topics, therapeutics, and diagnostic. But we rarely talk about how to develop a product. I think teaching on how to develop a product is essential. How to develop product is a complex process. It requires knowledge on the unmet needs, understanding intellectual property, business planning, the methods and endpoint for preclinical and clinical, the trial design, understanding regulatory strategies, reimbursement strategy, and the practice guideline requirement, and finally, adoption of technology. As you see, this is a truly unmet educational need for the future. Because of the lack of knowledge and the inefficient ecosystem for innovation, we currently spend about 15 years and $1 to $2 billion to develop one product. Contrast that to the coronavirus vaccine timeline. Currently, because of our education system, 1 out of 3,000 ideas and less than 10% of startup will succeed. What we need a robust system for product development, evaluate safety and efficacy in expedite manner, and recognize early a failing concept and stop spending resources in it, but also recognize a potentially successful concept and expedite the process to become a useful product to treat patients. The ISCTR was founded in the year 2007 to address the challenge of product development and standardize the method and the process, what we call today translational pathway for cardiovascular devices. That should expedite scientific discovery to patient, decrease cost, and save life without compromising the quality. Because of our outstanding governing board, we have collaborated with over 100 experts from a different background, academia, industry, regulatory, reimbursement agency, practice guideline, and patients. And as a result, we put together an educational program, include online course of 80 lectures, as well as an ebook of 400 pages on a product development, in addition to other educational material, including the Journal of Cardiovascular Translational Research that published by Springer and Nature bi-monthly. As a result, we have the online educational program about 5 months ago, and we have 5 universities has adapted this educational program to their graduate and postgraduate degree from medical school, engineering school, law schools, and others. So what we have completed so far, the translational pathway for cardiovascular devices, and in the future, we are working on the drug development as well as the biologic. And that's will be the example for other specialty to do their own. So I think in the future, expanding cardiovascular education into how to develop a product in addition to how to use a product will play an important role in bringing a new discovery to patients, saving life and decreasing cost. And I think the curve that was published by Professor Braunwald, showing us the decline in death from cardiovascular disease in relation to scientific advances. If we have a robust system for product development, the curve will be steeper. And thank you for listening.
Thank you, Nabil. Now, our next speaker truly does not need an introduction. If ever there was someone who didn't need an introduction, Dr. Eugene Braunwald is a professor of medicine and the founding director of the TIMI study group at Harvard Medical School. Dr. Braunwald?
So I'd like to take a very positive position about the elimination of coronary atherosclerosis. These are my other activities. Now, there is general agreement that there is substantial evidence from multiple different types of clinical and genetic studies that unequivocally establishes that LDL cholesterol causes atherosclerotic cardiovascular disease. The causal effect of LDL-C on the risk of atherosclerotic cardiovascular disease is determined by the absolute magnitude and the cumulative duration of exposure to LDL-C. This came from a group led by Brian Ferrers and published in the European Heart Journal. So Professor Neal talked about products, and I want to mention inclisiran. Inclisiran is a new drug that inhibits the development of PCSK9, which of course is a pro-LDL raising biologic. So by inhibiting it, it results in marked reduction in LDL cholesterol. And this slide is a summary of 3 separate trials in which inclisiran was given at an optimal dose, 300 milligrams, twice a year. I repeat, twice a year, 2 injections a year, in patients with familial hypercholesterolemia or atherosclerotic cardiovascular disease. And you see about 50% reduction in LDL cholesterol. It is possible to give it only once a year. And this slide shows the marked reduction between placebo in black and after a single injection of inclisiran. It goes on for a year. There is about a 40% reduction in the area under the curve. So if we consider the relationship between the LDL burden and age, you can see that for a normal person, the line that shows the cumulative cholesterol years, you think of cholesterol years is like smoking years, and they go up, and the red line is a threshold for coronary heart disease. In patients with familial hypercholesterolemia and 200 milligram per deciliter, you can see that that point is reached much earlier. And in homozygous, it's reached at the age of about 10. So you can see that the height of the LDL and the duration is what brings a subject. So the concept here is a 30-year-old person with an LDL of 100, normal LDL, treatment with inclisiran 300 milligrams once a year, along with the flu vaccination. The effect is a 40% reduction in LDL cholesterol. So this takes us back to the normal subject who reaches the threshold at the age of 70 years. If that patient or really subject is started at the age of 30 with a single injection a year of inclisiran, the 40% reduction would reduce it from 100 to 60 milligrams per deciliter. And that indicates that there is a 30-year prolongation. So by the age of 100, that subject will achieve the threshold. So I think this is one way of eliminating coronary heart disease. I think that the earlier we begin the prevention, and that can be done with genome-wide association studies. And these, of course, since the genome doesn't change, could be begun at birth so that high-risk patients can be identified very shortly after birth. And in that way, these two ways will eliminate coronary artery disease. Thank you.
Thank you so much, Dr. Braunwald. What a beautiful lecture, and what an outlook into the future. Our next speaker is going to be Professor Patrick Serruys, a good friend and a good colleague. Professor Serruys is Established Professor of Interventional Medicine and Innovation at the National University of Ireland in Galway. His talk that he will share with us is entitled, Will Interventional Cardiology Have a Role in Stable Angina? Patrick, please.
Will interventional cardiology have a role in stable angina? We could rephrase that title by asking the question, will stable angina be cured by pharmacological treatment? I don't want to be provocative, but what is the ultimate and secret theme of the interventional cardiologist, let's say in 10 years from now, is to get access to the genomic of young individual in order to catch with non-invasive imaging the early phenotype expression of their coronary disease prior to symptom of event. We call that imagomic and want to use non-invasive imaging to monitor disease prevention and regression induced by too early subcutaneous injection of a microbe messenger RNA to block the production of PCSK9. You will have understood that the secret and ultimate dream of the interventional cardiologist is to prevent surgical and percutaneous coronary intervention. Today, the chest pathway is the following: non-invasive testing, invasive coronary angiography, and ad hoc intervention. When we see a patient with new onset of chest pain, we interview the patient to assess his symptom, his risk profile, perform a physical examination, and then what is critical is to obtain an ECG at rest. If the ECG shows ST elevation, you rush to the cath lab for primary PCI and you save life. If the ECG is non-diagnostic and troponin normal, you enter the world of non-invasive testing, chest X-ray, echocardiogram at rest, stress ECG, dopamine echo, CTA, CT with perfusion, FFR CT, MRI with perfusion, adenosine SPECT and PET, name it. You start a symptomatic pharmacological treatment with vasodilate, a negative chronotropic and inotropic drug, and initiate a program of plaque prevention of regression with lipid-lowering statin, PCSK9, ezetimibe, benzoic acid, EPA. Maybe you use some inflammatory modulator like ziltivekimab, lowering your CRP by 97%. You control the glycemia of your patient and advocate a lifestyle modification. But if the diagnosis remain equivocal, if you have prognostic concern, if you face incomplete remission of angina, then you refer your patient to the cath lab and you have to cross a first line of invasiveness with invasive angiography. And in about 1/3 of the case, you have to cross a second line of invasiveness with an ad hoc intervention. But in 62% of the case, you will find either pristine coronaries or the coronary angiography was unnecessary, or you will disclose a non-obstructive disease, NOCA, which is bad news since it is a killing syndrome only amenable to pharmacological treatment. The future vision is cardiac CT at one-stop shop with angiographic detection of stenosis, fractional flow ratio, FFR CT, CT perfusion with hyperemia for assessment of the microcirculation, plaque anatomy, tissue composition, morphology, high-risk lesion, ejection fraction, wall motion analysis, Lemon score, syntax score, calcium mapping, and so on. You have to cross only one line of invasiveness and go to the interventional suite to perform a PCI carefully planned with non-invasive imaging, or you will refer the patient to surgery without prior invasive angiography like we currently do in the fast-track trial CABBAGE. But the future has arrived in the ischemia trial in patients with moderate of severe stable angina. Randomization between the conservative and invasive arm was preceded by CTA in order to detect a significant left main stenosis. A high concordance of 92.2% between CTA and subsequent invasive angiography was documented, and actually in this trial, CTA did replace invasive coronary angiography. This slide showed the probability of freedom of angina at follow-up by comparison with the baseline angina frequency in the conservative group in blue and in the invasive group in red. If the patient had daily or weekly angina at baseline, 45% of the patient in the invasive group became totally angina-free at 3 months versus only 15% in the conservative group. To achieve that kind of difference in freedom from angina, you need to treat only 3 patients. And by the way, that difference of freedom of angina persists and even improve at 12 and 36 months. The next slide showed the primary outcome in terms of cardiovascular death, MI, unstable angina, heart failure of resuscitated cardiac arrest. At 6 months, there is a difference of 1.9% in favor of the conservative treatment. At 4 years, the difference is 2.2% in favor of the invasive treatment. Obviously, there is no difference in all-cause death. Now, that contention has been recently challenged by a systemic review and meta-analysis of 25 randomized trials, including almost 20,000 patients published in the European Heart Journal. The title is Cardiac Mortality in Patients Randomized to Elective Coronary Revascularization plus Medical Therapy of Medical Therapy Alone. the relative risk of cardiac death is definitely reduced by a strategy of revascularization plus medical therapy and associate in a linear fashion with the duration of the follow-up. Overall, patients with elective revascularization had a favorable hazard ratio for cardiac death ranging between 0.78 and 0.80. And similar observation was done for spontaneous MI. In that last slide, will international cardiology have a role in stable angina? The management of stable angina after ischemia trial should be as follows. If left main is diagnosed by CTA, the patient should be referred to catheterization with the option of revascularization after discussion with the heart team. If the patient has no left main, we should consider this predicted prognosis based on functional assessment. What is the amount of ischemic myocardium at risk? If the prognosis is bad, or if the patient has severe residual angina after optimal pharmacological therapy, then the option of revascularization to be proposed to the patient. If the patient has a low level of angina and is satisfied, then he can continue his pharma treatment. And if the patient has a low level of residual symptom, but nevertheless remain psychologically unsatisfied or anxious, then revascularization could also be proposed. The question will remain, will stable angina be cured by pharmacological treatment? I thank you for your attention.
Thanks so much for that great talk, Patrick. Our next speaker is Dr. Martin Leon, and Dr. Leon is professor of medicine at Columbia University and the founding chairman of the Cardiovascular Research Foundation. And Marty is going to speak to us about the possibility that all valve therapy in the future will be percutaneous. Dr. Leon?
Thank you, Dr. DeMaria. It's a true pleasure to join this prestigious group at the European Society of Cardiology. These are my disclosures. With an aging global population, by calendar year 2040, we expect approximately 150 million people will have moderate or severe aortic stenosis or mitral regurgitation. And clearly, transcatheter valve therapies will play a major role in the management of these patients. But many of these therapies are at very different developmental stages. Transcatheter aortic valve replacement has been performed in over 1 million patients thus far. Transcatheter mitral valve therapies in slightly more than 100,000 cases. And transcatheter tricuspid valve therapies in only about 1,000 patients. So the certainty of prediction clearly is different for these 3 valve therapies. But I'm going to focus my crystal ball and tell you that in the next 5 to 10 years, I predict that certainly for the aortic valve, the vast majority of transcatheter therapies will be performed as the primary treatment modality, with a small minority of open surgical procedures. The mitral valve is more complex, and we expect that there'll be a significant minority of patients that are treated with surgery or medical therapy, and the tricuspid valve is even more complex, but we believe that the overwhelming majority will be treated with transcatheter therapies within the next 10 years. This field began almost 20 years ago with the first in-man pioneer, Alain Crebier, who did the first proof of concept TAVR or TAVI procedure, and that began a revolution in April 2002. At that time, we could never predict that we would see such a dramatic growth of this procedure, such that it exceeds the number of surgical procedures of valve replacement by calendar year 2018 in the United States. But we're talking about the future, and I'd like to focus on upstream therapies, which means earlier therapies. So we believe that this technique can be applied to asymptomatic severe aortic stenosis, and we're nearing completion of enrollment of the early TAVR trial. At-risk moderate aortic stenosis, another provocative group with 2 randomized trials, either planned or ongoing, and even aortic valve remodeling procedures or medical therapies in the future. This is an example of an aortic valve scoring device that can be used in extreme cases of aortic stenosis that are not candidates for valve replacement, or even earlier in the course of disease to modify the natural history of aortic stenosis. And there's much work being done in medical therapies right now for calcific aortic valve disease and for myocardial preservation in patients with aortic stenosis. Clearly, bioprosthetic valve durability will be an important consideration in the future, and we expect to see new polymer or bioprosthetic valve platforms which should improve durability profiles, one of which is shown here. So for the aortic valve, clearly transcatheter therapy will be dominant and become the default therapy. There'll be many evidence gaps that have to be addressed and resolved. The conversation will shift to valve durability. The upstream use of TAVR, as we've discussed, will become important, and innovation will focus on 2 things: the use of artificial intelligence and machine learning for screening and device phenotyping, and novel, more durable valve leaflet technologies. The mitral valve is more complex, and I'm showing here 60 different transcatheter devices that have been used in various stages of development. It's a complex disease with many overlapping solutions. Right now, the current winner has been an edge-to-edge repair device called MitraClip for both primary and secondary MR, with very exciting results of the COAPT trial in secondary MR presented only a few years ago. In the future, we see replacement therapies rapidly evolving with the landscape of many devices shown here, several of which are now applied using transeptal techniques. So the mitral vision will remain challenging in the future, with surgical repair for primary MR being important, and guideline-directed medical therapy still evolving for secondary MR as major contributors. We'll see growth in edge-to-edge repair, but we need more clinical evidence to expand indications. And TMBR replacement will play an expanding role, such that multi-device lesion-specific approaches will be the initial therapy choice, followed by combination therapies for recurrence or device failures. And finally, the tricuspid valve. Little is known about this previously forgotten valve. Imaging has been complex. Identifying issues relating to RV function are problematic. When to treat remains controversial, and the safety and value of transcatheter therapy is in early developmental stages. The main disease is functional tricuspid regurgitation. This slide shows the various new technologies that have been applied in 4 different categories: annuloplasty devices, leaflet devices, and various forms of valve replacement therapies. And how to choose which of these devices in what scenario becomes extremely important. There's little clinical evidence. Perhaps the best study is merely an international registry of many patients compared using propensity-matched registries of medical therapy, showing some evidence of early benefit of transcatheter devices versus medical treatment for tricuspid regurgitation. So the vision for tricuspid therapy, I predict there's going to be explosive growth as both sole therapy and combined with mitral therapy, and also upstream earlier treatment. Technology refinements are expected. Many things will be needed to make this a reality over the next decade, and we are seeing facilitated regulatory approval pathways with creative new clinical trial designs with 3 large ongoing randomized trials that have been started. So we see tremendous promise for transcatheter therapy in the future of management of valvular heart disease, with a predicted majority of patients, not all, but a majority of patients being treated with these techniques in the future. Thank you.
Thank you very, very much, Dr. Leon. What a superb, really true visionary lecture. Our last guest, our last speaker of this afternoon is Professor Pam Douglas. also a very, very good friend. And she is the Ursula Geller Professor of Research in Cardiovascular Disease at Duke University. The last speaker, but certainly not the least, in this wonderful session, Pam, we look very forward to your talk entitled Will Computers Interpret All Cardiac Imaging? Pam, please.
I'm delighted to present today to you on Will Computers Interpret All Cardiac Imaging? In answer to this question, there's a very quick response, yes, because they already do. Let's look more closely at this. Computers are already contributing to the interpretation of most cardiovascular imaging today. They already do image acquisition, image formation, management, display, enhancement, and analysis. This relates to patient profiling within traditional scan interpretation. However, tomorrow we will see images and computers used to provide much more information, from radiomics to machine learning to segmentation and processing and feature extraction. So we've seen the current applications on the left. Let's look at some in-progress applications and things that we may come across in the near future. In progress are workflow and efficiency, digital image acquisition, image reconstruction, segmentation or measurement, object detection or quantification, classification to make a diagnosis or exclude it, prognosis and outcome prediction. And in development, which we will see in the clinic in the near future, are things like using computer-based image analysis to plan our procedures, to create synthetic images, to measure tissue texture and composition, to identify molecular phenotypes, to make complex predictions, including integration with non-imaging data sets. I'm now going to show examples of the 5 bullet points that I've underlined here to give you a flavor for what work is in progress and currently being tested in the clinic. So the first is object detection or quantification, and this is the differentiation of each pixel according to the type of data included in it. Right now, investigators are developing artificial intelligence trained neural networks which can handle raw images and video loops from echocardiograms to extract useful information, including temporal and spatial data to segment the left ventricle. These algorithms can then perform critical tasks of estimating ejection fraction and strain, improving the assessment of cardiomyopathy. When compared to human readers, there's improvement, both being more reproducible, detecting more subtle changes, and making a more precise diagnosis. Here's information on computers and how we will use image processing to plan procedures. On the far left, you see an FFRCT images showing quite a hemodynamically significant lesion. In the top left panel, with a virtual stent placed in the bottom left panel showing marked improvement in the FFRCT data. In the middle panel, the angiographic images show pre and post FFR after placement of a stent in the region predicted by FFRCT. Finally, in the far right panel, you see comparison of pullback curves looking at pre-PCI with the FFR and above compared to the pre-PCI FFRCT, and then below post-PCI showing that both the actual FFR and the predicted FFRCT in blue are nearly identical. These data were presented at EuroPCR this year and show minimal differences, less than 0.04, between estimated post-procedure FFRCT versus actual invasive FFR. Here's the schema for how we might create synthetic images, in this case vascular images. We can take in pink the poor quality, disparate, incomplete, or sparse images created in reality in the clinic. feed them into an AI algorithm which also contains knowledge of vascular morphology, and result in images with improved quality, more coherent, complete, and denser imaging. We also create synthetic images as shown in the middle right panel. Identification of molecular phenotypes is an incredibly important area of very rapid investigation. The first step in doing this is to link the image characteristics on CT of the plaque to pathologically validated precursors of cardiovascular events such as inflammation, fat attenuation, and so on. And there are a number of these as are shown in the images, including a necrotic core, fibrofatty or fibrous lesions, calcified lesions, or highly calcified plaque. Currently, there are at least 3 companies that have real-time plaque characterization software using AI-driven image processing. You can see examples of their work here, which provide promise that in real time, in the clinic, in the CT suite, we will be able to not only image the coronary arteries and other vessels such as carotids and so on, but determine whether there are lesions there are concerning or not. Finally, we can take that information and use AI to combine these extensive and annotated image sets with other data libraries so that we have multidimensional data sets, which include genotyping, such as the polygenome risk score, clinical data like risk factors, and the plaque phenotype data to generate a personalized understanding of risk, which will enable precision care, including the ability to monitor therapeutic responses over time, which hopefully will lead to improved outcomes. Thank you.
So, Jean, that was a very provocative and exciting presentation. Clearly, the elimination of atherosclerosis would be an incredible step forward. A couple of questions, though. How do we really determine what the threshold is? And does that vary by risk factors, for instance?
Well, yes, it certainly does. And you've asked a very important question, as usual, Tony. Given the time of 6 minutes, I couldn't go into that in detail. But the threshold, this is an average threshold. And certainly in a high-risk patient, for example, hypertension, diabetes would lower that threshold. In a low-risk patient, the threshold would be higher. But so this is an average threshold. And in order to make this work, you have to also define the subject's risk without lowering the LDL, and then lower the LDL. What I didn't have the opportunity to say is this average was started at the age of 30. If you were to start it at the age of 40, you wouldn't get 30 years. You'd get about 22 years. If you started it at the age of 20, you would get 40 years. So it is highly variable, but I think you can certainly make that prediction. And the earlier you start, the better.
Patrick, you are one of the founders of interventional cardiology as we know it today. Let me ask you something. Let us brainstorm a little bit about the future. In 5 years from now, do you think that CT coronary angiography is going to be the gatekeeper for invasive coronary angiography? And do you believe eventually that with this non-invasive technique, we will be able to identify the vulnerable plaque on CTA so that we can do earlier intervention? Because I think earlier is the word that comes back in many of those talks that we heard today. So questions to you, CT as gatekeeper, and can we identify in the future vulnerable plaque and will we be able to treat that accordingly?
Yeah, Jeroen, I'm convinced that it will be the case. You know, if you look at the pyramid of the coronary artery disease, at the bottom, you have the rule out, and the multi-slice CT scan is doing that very well. You have the NOCA with the plaque in the vessel wall, but without encroachment. That's a good target for the pharma therapy. Then you have basically the 1 and 2 vessel disease functional for PCI. And at the top, you have the surgery. And as you know, we are in the middle of a trial where we go to surgery for 3 vessel disease and main stem without cine angiography, just with multi-slice CT scan. So if the surgeon can do that with the most complicated case, then the interventional cardiologist can do basically the rest of the patient. As far as the vulnerable plaque, yes, we are making progress. It's clear that there are long-term follow-up now in all the characteristic of the so-called vulnerable plaque, remodeling, microcalcification, thin cap, and so that's get more and more accessible to the multi-slice CT scan. And you have also the perifat inflammation, which is also quite reliable. Say to your both question, my answer will be yes, certainly in 5 years.
Very much, Patrick. Quite convincing, actually, and I also believe that we're going to go that way.
So, Marty, as usual, a very intriguing presentation. As long as I've been in cardiology, one of the vexing questions has been the timing of intervention in valvular heart disease that can occupy almost every cath conference. As we increasingly do things through transcatheter approaches, is that going to solve this question? Are we moving to earlier and earlier therapy?
Thank you, Tony. That's a very interesting question. Certainly our hope is to treat patients at an early enough stage where there's no long-standing either myocardial or other cardiovascular damage that can't be reversed. So this issue of upstream treatment has become fundamental. From the earliest days of the profound Ross-Brownwald diagram, we've been conditioned to thinking that symptoms should be the trigger point for treating many of the valve syndromes, particularly aortic stenosis. We're now learning that it's far more complex than that, and that many times that we can anticipate pre-symptom conditions that would warrant valve therapy. So this whole issue of predicting which patients and having a less invasive therapy that can be applied at an earlier stage, I think will be fundamental to the future of management of valvular heart disease.
Marty, let me also ask you a question. Fantastic talk as always. And I think you convinced all of us that the transcatheter treatment is going to become the technique to treat heart valve disease in the future and probably already today. We've learned in all these lectures that just passed that earlier, right? And Dr. Demaria just mentioned it again earlier. When do you think that the use of pharmacological therapy in the treatment of heart valve disease, particularly aortic stenosis, is becoming a reality? And one other side question that I have, do you believe that injectables in this field eventually will also be possible to prevent even, and I'm talking only for the moment about aortic stenosis, to prevent aortic stenosis?
That's a very provocative question. We've had some false starts with pharmacologic therapy for calcific aortic valve disease, but I see a reemergence of excitement with new drugs, new approaches, injectables, looking at ways to be able to identify patients either by a variety of imaging techniques or with genomic expression to be able to characterize a patient substrate that might be more amenable to pharmacologic therapy to delay the onset and change the natural history of calcific aortic valve disease. And we expect to see in the next 3 years some very interesting multi-drug and parallel drug studies that will be initiated along these lines. I also think that it's not just the valve that we're concerned about. I think that there's significant changes that occur at the myocardial level, and there are a variety of drugs today which can potentially prevent some of the deleterious effects of chronic afterload impact of aortic stenosis on myocardial function and structure. So I think those studies also will begin. So it's a combination of delaying the onset of disease and its progression, and also treating the effects of aortic stenosis that will be in the domain of a variety of pharmacologic approaches as adjunctive therapy in the future.
Thanks very much, Marty. Truly a view of the future. Tony, I'd like to ask you to say a few words, and then I will, after you, close the session.
Well, I think this presentation has clearly shown that the future of our management of cardiovascular disease will be extraordinarily exciting. Of course, we have visionaries that have done the presentation, people who've actually been in the forefront in advancing all of this. I remain very excited. I just can't wait to see what we'll be able to accomplish in the forthcoming years.
I feel the same, exactly the same. I think we've had a truly magnificent joint session between the ESC and the International Society of Cardiovascular Translational Research. And I'm very glad that Nabil Deep has put so much effort in making these things happening. I think we truly enjoyed this. I would like to thank all the speakers for their spectacular lectures, providing us a glimpse into the future as they see it coming, as we see it coming. I would like to keep it very simple and conclude as follows. Cardiology of today is great, but the future is going to be even better. Thank you very much for attending this session.